So I never use those factors. Thank you so much. Thank you. I'll put it up. So I don't use those correction factors because those are just estimations, okay? Put it in my pocket or in this pocket. How about that? Okay, good. Now good. I'll speak slowly then. So temperature, always remember, okay? It's very important. Let's talk about the real artifacts, okay, which I was showing you. One is this one, the enlisted electrodes impedance and mismatch. And I was seeing that all the time today because they were not sticking. The gel was going all over the place. Man, this is not the way I do, honestly. But that's good to show you the artifact. Because what happens, the theory is both these electrodes, the recording and reference electrode, when you have two electrodes, they should be at the same impedance. Anything which is coming to one electrode, not the other, will be amplified. The two electrodes are designed to maximize the difference between the two electrodes. You see that point? So one, you stimulate a nerve, anyway, to the G1 or the E1, which is the recording electrode. The one on the tendon is at a neutral, so there's a difference. It amplifies that difference, okay? As the current flows down to the other side, to the reference electrode, you see the positive peak. So you see the biphasic. The biphasic response is because of that. First, the depolarization going to the recording electrode, so it goes an upward peak. And as it reaches the reference electrode, you see a downward peak. You see that? That biphasic is because of that difference. When the potential is traveling towards the recording electrode was going away. And that's what means phase cancellation as well. If they were too close to each other, they will cancel, the difference will be not as much. So when you have electrode coming off or gel, whatever, and you saw the 60 cycle artifact as well, is because they are recording differential potentials. And those causes a lot of artifacts, okay? Those cause 60 cycle artifact. It causes the baseline because it changes. And so it's very important to, and the way to correct that is, I was doing all these today. I was trying to secure the electrodes pretty good. I was trying to make sure the contacts were good, cleaning all the time. You saw that ground between and using coaxial. This is a coaxial electrode, luckily. What we have is a coaxial. They run in the same cable. Sometimes you've got not coaxial, they run separately. And that electrodes cause a lot of artifact. This is good over here. So anyway, there are different ways to correct this artifact. This is the most common artifact you will get. And EMG labs are, that's why studying done in hospitals, bedside, are very difficult because of all the instruments there, electrical, defibrillator, whatever. So those causes a lot of artifacts, and this is what it is. So different ways, cleaning the sink pretty good, making sure they're secure next to the skin, there's no gap, and all the jelly and all the, not too much jelly, because it also causes a problem, okay? Filters, I showed you the filter settings today. So the filters, there are two filters in the machine. One is in a high frequency filter, a low frequency. I won't go in detail at your level, but there are ways you can use the filters. For example, the ECG artifact is a low frequency artifact, slowly. As compared to this is a high frequency artifact. You saw that today that this artifact affects the sensory nerve because sensory nerves are very sensitive to high frequency artifacts. And the way you use them is that you can see the filter settings over here are much different for motor and sensory because they are prone to different artifacts. And so when you see this artifact, what you can do is turn on the high frequency filter. And as you do that, it's allowing 20 kilohertz frequency, 10, and as you go up there, by cutting off all the high frequency from 20 kilohertz, you go to 1 kilohertz, you can see what happens. It flattens. So that's one way of dealing with the artifact. And a cheat technique is, to do averaging. This is called averaging. There's a lot of artifact there. It's coming at different times. If I keep stimulating this nerve, slowly it'll pick up the potential which is coming at the same time. So I was able to get a sensory response over here by repeatedly stimulating. It's called averaging technique, and we do that to get rid of the artifacts, okay? There are ways to cheat things, but there's something we can do if you're stuck in somewhere you can't get rid of the artifact. I showed you this again in the morning, stimulus part. You have to have high enough to, we did this in the morning, you have to have high enough to excite all, not sub or supra. It has to be enough to, and then you get to a supra maximal. So you want to make sure you're on the electrode, your stimulating is on the nerve, small movement off will do that. You want to make sure it's really, and then you do the optimal position of the stimulating electrode and supramaxillary. I showed you that. Get the maximum, go above by 20%, okay? I'll use this over here. I told you if you go too high, you saw me, I was going by small increments, 5, 10. Don't crank up to 30 and 50 and 60. You go slowly, okay? And that will reduce your stimulant, also the movement artifacts. The limb, the stronger, if it suddenly jerks, everything will move around. So you want to go gently on the stimulus, but make sure that it's enough to do that, okay? And I told you about, just a caution that in demyelinating neuropathies, sometimes you do require more stimulus strength because the nerves are less excitable. But otherwise, you should be able to. Just a guideline. For sensory stimuli, I rarely go above 30. Rarely. Maybe 35, 40 in people who are a bit bigger. But by 30, you should get a pretty good response. Motor depends where you stimulate the nerve. Some nerves are very superficial. Trapezius at the neck, accessory nerve, by 15 millivolts, 15 milliamps, you can get a good response. Okay, as compared to deeper nerves. For example, if you stimulate a tibial nerve behind the knee, popliteal fossa, you get a high stimulus, you need a very high stimulus. So yeah, it depends on the site, but sensories, 30 should be good. Okay. I told you about sensory, we saw that in the morning, I don't want to repeat that myself. You can see this is what happens, the takeoff. And so what you can do, I showed you again, you can reduce the impedance by doing all those things. And I showed you this technique which people rotating the anode over the cathode. So with the stimulation, we can just rotate the polarity of this, it'll help. Okay? And so rest of you already know. And you also can reduce the stimulus duration, okay, from 1 millisecond. So typically you can do 0.5 millisecond duration of the pulse. Sometimes you go to 2 milliseconds. In big people, sometimes you go to 3 milliseconds as well for motor. Huh? But in sensory, you can go to reduce strength and reduce duration. Those will change things around. Okay, here's the thing I told you in the morning, this positive dip. It's overstimulation, okay? And then I'll go over this positive dip shortly again, but this is overstimulation right there. Electrode placement sensory. Okay, that's one of the common artifacts again. It has to be on the nerve itself, okay? The more off you are, there'll be volume conduction. Let's say the sensory nerve, let's say the radial is right over here, okay? Right on the 10, can you feel your radial? Have you felt your radial nerves? Radial sensory? You can feel it. If you roll your finger on this tendon, the radial sensory is right there. You can feel it rolling under your skin. If you're off that nerve when you're recording, a little far, you'll have this kind of stuff where the stimulus, the potential is being recorded far away where it's going. And so if your position is not right of the nerve, you will have a problem, okay? And I told you about this inter-electrode distance. This inter-electrode distance in sensory responses is about 3 to 4 centimeters, ideal distance, because it maximizes and I'll show you that, what it does. Here's the distance. So When your nerve, what we're talking about phase cancellation. When the first nerve gets records the potential, the reference electrode is still at a neutral, so you get the maximum difference between the two. If they are too close together, the potential on the first one is still going till the second one also reaches it. So there'll be a phase cancellation artifact. You'll get a lower amplitude. That's why ideal distance is you can see this is called phase cancellation right over here, because two phases are overlapping, cancelling. If they're too far apart, 5, 6, 7 centimeters, you'll get sounding noise, background noise a lot. So that's why ideal distance, make sure, is not farther than 4 millimeter. This is a common artifact, that's why I want to go back to you. What do you mean by this positive dip over here? What do you mean by this positive dip? A number of things can do this positive dip, okay? In the motor response. You know the motor response is belly tendon. The recording electrode has to be on the motor point, which is typically in the middle of the muscle, where the nerve is entering the muscle. It's called the motor point. That's where ideally you should have the recording electrode. If you're off that, there'll be stimulus coming from distant side and you'll get this. So always check your recording electrode if it's on the motor point. If you're getting this positive dip, you move your recording electrode, okay? Sometimes anatomically patients may have a motor point a little further down or lower down. No, everybody's not similar. But the rule of thumb is middle of the thenar muscles and ulnar middle of this hypothenar. Sometimes in ulnar, you may have to go a little proximally. But you can, with experience, you can easily find that motor point, okay? The other thing is I told you, overstimulation, I told you. If you stimulate multiple nerves, multiple muscles, there'll be volume conduction you'll get. So that's another artifact. Atrophic muscle. If you've got bad carpal, if you see a bad carpal tunnel where the muscle is atrophic, the motor point has moved. And no matter what you do, this artifact is hard to get rid of because the muscle is severely affected. Sometimes you have to accept that. But note in your report that this is a problem, and you've got a positive artifact there, positive dip, and that's probably affects atrophy of the muscle. Okay. Finally, let's talk about this. I think it's Dr. Ahmed mentioned that. So, the other thing you want to talk about is the reference. So I talk about recording electrode. What about the reference electrode in motor studies? If it has to be on the tendon, okay? If this is not enough, if both are in the muscle belly, that can be a problem because the reference and recording electrode, the potential maximized. So for example, in the leg, the tibialis anterior, if you're recording from tibialis anterior, the muscle, the belly is very far, you have to be on the tendon. They have to be like 15 centimeters apart. Has to be on the tendon, not on the muscle itself. Otherwise, you'll get a lower amplitude because both electrodes are now recording the motor response and the difference between them is reduced. Do you get that point? So both in sensory and motor studies, the distance between, in sensory, it's about 3 to 4 centimeters. In muscle, it's not fixed, it's belly and tendon, depending on the size of that muscle, okay? So let's talk about this. Anomalies, this is a common thing you get in nerve conductions. And it was mentioned, two situations. One in the wrist, hand, one in the limb. If you are getting a high amplitude distally and low amplitude proximally, this is a definition of conduction block. It was covered in the morning. 20% reduction is suggestive, 50% is definite. When you diagnose somebody with a conduction block, you make a diagnosis right there. There's a focal demyelination taking place there. If it happens in multiple nerves, then it's a demyelinating neuropathy. If it's at one point, it's an ulnar neuropathy or whatever. So when you get this, which is common, ulnar neuropathy is very common, below the elbow. So typically, you get this conduction block around the elbow. So you stimulate here, record, below the elbow you record, and above elbow you record. Typically in ulnar neuropathies, the conduction block occurs around the elbow segment, so between this and this stimulation point. This happens below the ulnar, below the proximal stimulation, below the elbow. Typically, there should not be a conduction block with this point and this point if there's an elbow ulnar neuropathy, because ulnar neuropathy is around the elbow. So if you get this kind of picture on below elbow stimulation, suggesting a 20, that should always raise before you can make a diagnosed conduction block. And there's a way to check that. I think Dr. Ahmed, the other position is where you get in lower limb. It's called, you got a low response distally, but a highest response on proximal stimulation. That is reversed. Typically, you get a little higher distally, and because the nerve is a bit deeper. If this happens on around the fibular stimulation, this is anomalous innervation. And the way to check that, I think we have the time. I think Dr. Ahmed covered that. This is important because of the elbow. And so if you're getting this picture of flow, either you're not stimulating enough below the elbow, it's under stimulation, or you're overstimulating at the wrist, getting a overstimulation, or you've got anomalous innervation, okay? Anomalous innervation, I don't want to talk about pseudoconduction block, I think this already is, but anyway. Here's what you call the Martin Gruber, the same picture he demonstrated. It happens very commonly in about 20% of patients that the ulnar nerve fibers are going with the median nerve. Around mid forearm, they leave the median nerve and join the ulnar nerve. You see that? It's a normal anatomical variation. They are just hitchhiking right from the brachial plexus. It's a normal, the fibers go into the, travel along the median nerve. Around mid forearm, they leave median nerve, and they are ulnar fibers, but they're just riding with the median nerve, and then they get to the muscle. So what happens is, when you stimulate the ulnar nerve over here, you stimulate these fibers, you get a big response. But you stimulate the ulnar nerve over here, because you're not stimulating those fibers, you get a lower response. Simple as that. So the way to confirm that is by stimulating the median nerve over here, because the fibers are with the median nerve, and recording at the ulnar nerve. So here it is. You stimulate at the median nerve, you get a small response there. That confirms that it is actually the fibers which are riding with the median nerve. Is that point clear? We see that the reason I'm pointing that out is because you're getting a lower CMAP proximally. It's an important finding. How to deal with that? So make sure that it takes seconds. Just put the electrodes here, stimulate the median nerve at the wrist. No response because those fibers are left. This is the median response at the wrist, recording at the ulnar nerve. The fibers have already left, but if you do at the elbow, below the elbow, you see a response at the, it's very quickly you change the electrode, put it here, and record here, you'll know it right away. Good? Here's the fibular nerve, accessory fibular nerve, or accessory peroneal nerve. This is a scenario in the leg where you got a regular amplitude, low amplitude distally because you stimulate, and then you got a higher amplitude proximally at the, this person has got accessory fibular nerve or peroneal nerve, which is going in the leg, goes around the lateral malleus and then takes a different course. The deep peroneal nerve comes straight to the muscle, extensor diatom brevis, EDB is the muscle, not at tibialis anterior, I'll show in the foot. And then the accessory peroneal nerve reaches the nerve to a different route. So if you stimulate over here, the glutes are small, but over here, it'll record both, and so you will get the full response. Good? Simple. That again is about 1/5 of your patients, 1/6 to 1/5 of your patients, so it's not that uncommon. Okay, I covered that in the morning too. Limb position and measuring. Measuring artifact will artificially reduce or increase your conduction velocity. More common is it increase you because I told you the measuring, this is simple measurement, okay, straightforward. But when you measure the elbow, when you're stimulating the hair here and recording the distance over here, This distance is smaller as compared to the nerve, which is, you can see how my fingers. If I do this, it comes smaller. You go this, so you have to measure this distance around the elbow in between 90 to 120 degrees of elbow flexion. Okay, so you go around and measure that, and that's what common mistake is, getting artificially abnormal velocities. Sometimes very high, or sometimes too low because you distance, so you get a lower conduction velocity there. I think I'll cover all those. Remember, this technique is very important. Make sure that these things you look for as a starting off when you're starting to learn. Get your techniques adequately sort of uh, optimized, so that when you do as a habit, you don't have to go in on as a habit. You inculcate that habit, that you clean, check the temperature, make sure that all the movement and all the stuff, limb is at rest. Initially, I was studying the hand, limb is hanging. There's no way to nerve conduction studies. You have to be completely at rest. Patient has to be a bit loose. Okay, it's just very important because you do it once and you do it good. Otherwise, you'll be dealing with artifacts. I showed you the common artifacts and their remedies. And if for some reason you can't get the whole nerve cluster, whatever, you mentioned that in your report, that uh, we were able to study one muscle only, and it's suggestive of a possible denervation at the nerve root level, so it's hard to localize. If I stick a paraspinal, it's abnormal, but I can't do the limb, or vice versa, then you can put it that in your report that is suggestive, but we couldn't complete the study. Same for sensory or motor studies, whatever, because of technical reasons, the study was incomplete. The best we can tell you is this: don't jump to a diagnosis. Keep options open. Okay, I think I'll stop here and take any questions. Actually, you know what? Let me quickly cover this as well because we've already done this. It'll take 5 minutes. We've already done the F response. There were a lot of questions about F waves. Uh, as it was covered, I just want to tell you people are asking me what is the utility or whatever. I think somebody came to lunch break as well. Okay. So first of all, it requires supramaximal stimulation. We typically record at the distal sites, but can easily be recorded at the proximal site as well, if stimulation, but typically record at the distal site. Supramaximal stimulation, okay. It's a purely motor. The response travels in both directions, toward the muscles and toward the spinal cord. Stimulates few motor neurons, and it fires back. So the motor neuron, the current gets up to the anterior horn cell. The same anterior horn cell fires back from its axon. Each time you stimulate, 2 to 5 neurons fire. So that fires a very small response. The latency, the time it takes. So the advantage of this response is as follows. As compared to these studies, it records from all the way proximal nerve to the spinal cord, anterior horn cell, and the axon proximally. It's not just the nerve roots, guys. It's not a nerve root response. It's the whole nerve, all the way to the spinal cord and back. So what that means is, again, it's a pure motor. It is variable each time, where latency and morphology. That's a hallmark. There are other late responses which are identical each time. There's an A wave, there's an H reflex, won't go there. But this is the hallmark of this response, variable latency and amplitude. Okay? That's how you recognize it. Upper limb is about 32, 33 milliseconds in the upper limbs, lower limbs about 61, 62 milliseconds. The time it takes to do the whole thing, okay. I say 35, 65 over here, I've been generous, 30 to 3.5 labs. The most important is not absolute latency, it's side-to-side difference. When you want to do it, is absolute plus if there's median, if you're doing simulation at the same site in both comparing, 2 milliseconds in the upper limb, side-to-side difference, 4 milliseconds in the lower limb. So both peripheral nerves, you do it, that difference are suggestive. Now, what is the use? Where do you use it? And people keep coming to me and ask me, nerve root. Yes, nerve root it depends on nerve root, but not alone. In radiculopathies, until you have got a polyradiculopathy versus more C7 radiculopathy or C5 are very common. Typically, nerve conductions are usually normal, including F waves, unless you got a severe one where you lost your CMAP. Needle studies are much more useful in radiculopathies. These are useful to rule out, for example, somebody has got a C5 radiculopathy. You expect these nerves to be normal. There is no polyneuropathy. C7 radiculopathy. Typically, the nerve, until there's your radial, and radial 2 will be in severe cases. F waves, because muscles are supplied by multiple nerve roots. All shoulder muscles are C5, 6, all except the pectoralis, C7 mainly. All shoulder muscles are C5, 6. So, because of multiple nerve roots, a C5 nerve root compression may not show up. Secondly, it only affects a very small area, the radiculopathy. The nerve is compressed in a very small area. So the response gets diluted. It goes all the way back and comes down to pick a latency prolongation in a small area until it becomes too severe, it will be hard. So in single nerve roots, it is not that much affected. But if you got a polyradiculopathy or a polyradicular neuropathy like GBS, it's very sensitive, okay? So it's very useful in early Guillain-Barré syndrome. And I find it extremely useful. Within the first week, even sometimes the CSF protein is not that elevated in the first 10 days, sometimes. But you do the rate responses, H and Fs, the most sensitive, 90% sensitivity is reported. So I really look, so in the initial few days, a patient presents you in 3, 4, 5 days, it's possible that the CSF may be borderline elevated protein. But this would show you the difference. GBS is a polyradicular neuropathy, nerve roots and nerves, and so it's very useful. Peripheral neuropathies, of course, demyelinating, affect the large nerves, larger portion of nerves, very useful. It's very useful in following the course of the disease, response to therapy, if the patient is stable versus getting worse. F waves are very stable. They, in a person, if you record it repeatedly over time, you'll get it in a very narrow range. It won't happen that today I check your F wave, it'll be 30 milliseconds, and 5 days down the road it'll be 24 milliseconds. It's very stable, around 35, 30, whatever the number is. So anyway, it's good to follow the course of the disease, and okay, I've covered that. We talked about minimal F wave latency. These are, I don't think at your level you need to, F wave persistence, you saw that in the patient, we got hardly 5. So, but F wave, minimal F wave latency, okay? That's about the F wave. We haven't covered the H reflex, we'll talk about that if we do it. And I talked quickly about neuromuscular junction. The neuromuscular junction we talked about, it's a very technically demanding study. I showed you how it is done. And here's what I wanted to show you, is this. Okay, so what you do is normally you can stimulate 100 times, the muscle won't show any decrement. It'll persistently. Our body, we got enough safety factor, meaning we release much more acetylcholine each time I stimulate than is needed to activate all the receptors, okay? This is called a safety factor. So if you require 10, you release 100. So you got a lot of safety factor there. But in myasthenia or other neuromuscular junction disorders, that is reduced. So after stimulating certain time, you run out of the acetylcholine. So this is what you get. What I wanted to show you was a decremental response. Maximum decrement between the first and second, worsen second, third, fourth, and by fifth, it improves. It's called a U-shaped envelope. Okay, and that's what we look for. The most common is this is the U-shaped. And all they look for the maximum decrement here, and then plateauing by fourth, fifth, and getting better. Okay, this is what the hallmark is. I told you about 3 to 5 hertz. That's the time required to get the maximum decrement because there's no buildup of calcium at that frequency. If you stimulate it too fast, there's a chance that you may build up calcium there and it'll hide the decrement. So 3 to 5 hertz is the ideal duration, the frequency. It's not specific for myasthenia, by the way. You can see it in other disorders too, LEMS, botulism, sometimes in advanced myopathies as well. It's not specific, but in the right setting, it tell you the diagnosis, okay? I told you all this, I won't go in detail. Positioning is very important, right? On the all these factors. One thing we want to do is check multiple muscles. We do at least 3 muscles, sometimes 4 muscles. You want to make sure that you stimulated the nerve supramaximally. Movement was not a problem. And it is when you facilitate, the common thing what happens when you exercise the muscle, the things move around. You're recording or stimulating electrode move because of the exercise, you're moving your hand, so be wary of that, okay? Always see it's reproducible. The motor's morphology of the motor responses is not changing of the CMAPs at each stimulation, okay? This is important. Somebody asked me this. You have to hold the master of the patient is taking that. It'll hide the decrement, so make sure that Botox is very common. Botox these days does not affect, but it does affect the single fiber. Botulinum toxin works at the neuromuscular junction, as you know. So in patients who receive Botox, I'm not sure, but for single fiber is out. We never do single fiber in a patient who has Botox in that muscle or any muscle. Very sensitive. If a patient had recently Botox in their face or whatever, wrinkles, you want to make sure that that's not the case because it'll cause an artificial decrement, okay? But hold the medication 24 hours prior. I think this is the classical decrement, 10%, all those rules, okay? It improves after exercise and then get worsened over time. But here is what we call the hazarded decrement. This is common. So if you see this waveform, this machine will tell you there's a 40% decrement. But this is not, so I wanted to show you some examples. You can see the maximum decrement is happening here. That's not right, it should happen here. Okay? This again similar to variable decrement. Machine will compare this and this or this or this. Depending on the machine setting, it'll tell you there's a decrement. But this is not correct. It is not going the smooth way. There's still quite a bit of decrement, but it should go smoothly. So waveform, looking at the waveform is very important because to see where the decrement is happening. Don't believe the machine. It'll just throw numbers at you. It'll just compare first by its settings, it'll compare the first and fourth or fifth. It won't take care of these. So you have to visually see that. Okay, good. I won't go into single fiber. It doesn't add much, but someday, if we meet again, I'll show you single fiber, not today. Sensitivity is much, much higher. Single fiber is like this sensitive in the right hands. Depending on the ocular myasthenia, 50% sensitivity. Rapstim are not that sensitive in ocular myasthenia, 50%. In generalized myasthenia, about 70%. But single fiber is okay, but that's for another time. Excuse me. Lambert-Eaton myasthenic syndrome, you see the decrement at low frequencies, 3 hertz. But you do at 50 hertz, you stimulate it fast, very painful, never do it. It's for textbooks. There's another way to diagnose Lambert-Eaton, I'll show you that. This one is very high frequency stimulation, 50 hertz. You see the increment is because of a build-up of calcium. So calcium does not get enough time to get out of the cell at that high frequency, and that's the defect in Lambert-Eaton. There's calcium entry defect. If you correct that, you'll get this 200, 400% increment from 3 millivolts. What's the hallmark? Okay, somebody who tells me this is small, I'll be very impressed. What do you see in Lambert-Eaton myasthenic syndrome in nerve conduction? Who said low amplitude? Somebody said that. That's right. CMAPs across the body. The first patient I saw in Lambert-Eaton myasthenic syndrome, I couldn't get more than 2 millivolts CMAP. Normal CMAP in median is 10, 14, 16, 18. Okay. I ran to my supervisor. I said, I can't get a motor response. See, 22 millivolts. They're very severe, good job, severe neuromuscular conduction defect. So the indication for that would be nerve conduction will be that generalized CMAPs, sensory will be normal. CMAPs will be low amplitude. Normal latency conduction will be very low amplitude generally, like a motor neuropathy. Okay, like a motor neuropathy. but it will be all over arms and limbs. The best way to diagnose that is just exercise them for 10 seconds. 10 seconds. This is at baseline, 10-second exercise, you get a 200% increment. That's your Lambert Eaton. Nothing else does that. So within 10 seconds of exercise, if you've got a very low CMAP and suspecting that, you get a 200% increment after 10 seconds. That corrects the, and that's Lambert Eaton, okay? But just for the textbook sake, you can do rep stems at low frequency, you'll get a decrement, at high frequency, you'll get increment, okay? I think that does it for, okay. I think we'll move on to needle, is it? Or what is there a low limb? Oh, sorry. Or we, okay.
Hello. It's my pleasure to be here with Professor Zaim in this workshop, and I would like to thank Dr. Radwa for her activity preparing this workshop. Actually, my lecture it will be very basic because it's very difficult to explain some technical points and a lot of technical details in a theoretical lecture. I guess the hands-on training, it will add much more value. First of all, I want you to rely on this rule. EMG, nerve conduction, and in electrophysiology, it has to be combined with the clinical history, the clinical examination, and the hypothesis you generate after doing this clinical evaluation. And it's always will be beneficial if you correlate it to the clinical theory or the clinical hypothesis you have assumed after doing the clinical assessment. What's electromyography? Electromyography, it's a recording for the electrical activity inside the muscle. But please, I want you to add another information. It's a recording for the electrical activity inside the muscles and not for the muscle only. Also for the motor neuron that supplies this muscle. As you will see, the changes in the motor neuron will affect the recording of the EMG. And we have to agree to a very important concept. It is the concept of motor unit potential. The motor unit potential is the generation of the nerves supplying group of muscle fibers. Please remember these concepts. When I record the motor contraction, I record a motor unit potential. So again, what's motor unit potential? It's a motor neuron supplies group of muscle fibers. This is a diagram showing the, the motor nerve supplying a group of muscle fibers. So again, this concept has to be settled in our talk. Nerve supplying a group of muscle fibers. What do I know? I need to perform an EMG. I need a needle and first a grounding system. And the grounding system is very important in recording of the EMG. The grounding system in the motor conduction, I look for signal in millivolt, not in microvolt. But sometimes in recording the EMG, I have to look for recording in microvolt, like we'll see in the positive sharp waves and some spontaneous activity. I need also the EMG cable, and I need the machine containing the amplifier and the recording on the screen. Added to this, I need a lot of experience and I need a lot of technical setting. Remember that the technical setting will make so much difference. If I do the good or correct technical setting, this will help me get good results. Because, for example, when I do the technical setting during resting activity, if I set my machine to detect in one place in millivolt, I look for wave in microvolt. So remember that I have to do the good setting or the correct setting. Adjust your machine. And this will come with experience. Also, I have to arrange with the patient the maximal condition that will help me get correct results. For example, during the resting state, I have to be sure that the patient is totally resting during the minimal contraction, during the maximal contraction. So it's not only related to this preparation, the needle or the cable or the machine, it's also related to the setting you prepare regarding technically or regarding arrangement with the patient during the procedure. So first you have to explain the patient. We will go through certain stages. I'll examine you in the resting state. I'll examine you during minimal volitional contraction, and then I'll invite more activity to occur, then reaching to the maximal contraction. So remember this, it's not only the machine, it's your experience, your preparation with the patient, and your adjustment for the parameter during the recording. Then you will wait for what the sounds and the waves will tell you. And to know what the sound and waves will tell me, I have to be aware of the normal finding. So we will go through the normal finding first. And as you notice, I have commented on both sounds and waves. It's not only the waves, because in EMG, you have to adjust your volume. You have to be aware of the sounds of your finding, of the sound of the wave, whether during resting state or during contraction. What's the normal for EMG? Actually, I have told you we will go through first the resting state. Then during the resting state, I will do insertion for the needle. Then I will record what's called insertional activity. Then I will order the patient to do minimal contraction. And then I will invite the patient to do much more contraction, reaching the maximal contraction, what's known as recruitment of the motor activity or motor unit potentials. Normally speaking, the muscle during rest is supposed to be with no activity, as you see here. So forget about this part. It will be in the pathology, and look at this part. Here is the resting state. There is no activity for muscle during resting state. And then when I invite the patient to do minimal contraction, I'll find the motor unit potential. Then when I invite him to do the maximal contraction, I will do recruitment for more and more motor unit potential until I reach what is called the interference pattern. So remember these concepts. First, resting, then minimal contraction, then much more contraction, reaching what's called the full recruitment and full interference pattern. Normal during rested state, there is no activity. When I do insertion activity, there is a brief action potential. Only when I go with the needle through multiple motor unit potential, so I can record from multiple of them, but it's a short one until the needle is resting at certain motor fiber, motor unit potential, then it will be recording from this only. And I ask the patient for contraction. Here I can record the motor unit potential and then the recruitment. If we settle at this protocol, then we will move to, and we have known the normal finding in this protocol, we'll move to the abnormal finding. But before moving to this, please be aware of some normal finding I could find during recording, and by mistake, sometimes I can consider it as abnormal or pathological. So be aware of what's called end blade potential. Normally speaking, at the wall of the muscle fibers, there is electric activity. When the needle at the tip of the end plate, it can record the end plate potential. This is a normal finding. How could we differentiate it from other abnormal finding like positive sharp wave, like fasciculation, like fibrillation? Actually, the end plate potential, it's always, the wave is negative wave mostly, and mostly it's associated with pain during insertion of this activity, and also irregular. So you have to characterize it, and this is a photo for the shape of the end plate potential. As you see it's negative. You all know that in neurophysiology, the negative wave, the positive wave is downward, and negative wave is upward. So the end plate potential mostly is a negative wave upwards, the very short duration associated with pain, and due to interference with the end plate of the recording. Here, the normal motor unit potential, and we have to agree to certain concept with the motor unit potential. What do you look for in the motor unit potential generated on minimal contraction? You will look for its duration, and this duration, it's from start to till the end of the motor unit potential, and normally it's from 5 to 15 milliseconds. So we have to know these numbers. And what is the amplitude? Is the amplitude from the baseline to the peak, positive or negative peak? The amplitude is from the lowest point up to the highest point. So it's from here to here. This is the amplitude. So the amplitude from the negative peak to the positive peak. And the amplitude, normally actually the amplitude number is variable related to the age, related to the type of muscle I record from, related to the state. For example, I have mentioned in the definition that I can record by a needle electrode or surface electrode. Actually, surface electrode is much less accurate, and mostly you can find the amplitude of the wave is less than the supposed to be recorded. So remember that the needle EMG is much more accurate in recording these parameters. Again, I have talked about the amplitude, the duration. What are the phases? The phases is the number, the wave crossing the midline. So for example, in such a case, this is a phase, another phase, and another phase, and so this is triphasic one. And turns are different from phases. Turns is the change of direction. For example, this is a turn, but it did not cross the midline. So it may be with 4 or 5 turns, but with only 3 phases. And mostly we rely on the phase. What's the normal for the numbers? As I told you, for the duration, it's from 5 to 15 milliseconds. How about the amplitude? I told you it's a variable, but most of textbook consider it from 300 microvolt to 3 millivolt. Sometimes a lot of other books have written it can be normal up to 5 millivolt. Some textbook I have read it's 2 millivolt or some lectures. So mostly we consider it from 300 microvolt to 3 millivolt. These are the normal motor unit potential, and this is a recording for its parameters. The duration, the phases, the amplitude, and this is called the rise time. This is time taken from deflection from the positive wave to the peak of the negative wave. But we have a note here on the phases. Normally, if the wave is polyphasic, a lot of phases, this is a sign of pathology. But it can be accepted, it could exceed 3 phases to be something like 4 in 5 to 15% of the recorded motor neuron potential. So if I find one polyphasic while the other are normal, or 2 polyphasic waves while the others are normal phases, meaning 3 or 2, so don't consider it pathological. To be polyphasic, it has to be much of your recording as polyphasic waves. So this is final description for the normal. It's from 3 to 15. I've told you 5 to 15, and this is the amplitude, and it could be biphasic or triphasic, and accepted to be with some polyphasic like 4 phases. This again going to the concept for the normal recording. This is minimal effort, then I doing more effort, then I am reaching the full recruitment. And what's the recruitment? As I told you, I invite more motor nerves to stimulate more motor fibers, so a lot of motor unit potential are activated. Then I find the word describing this condition, which will be the baseline is obscured. I can't find the baseline, and all the motor unit potential are condensed and beside each other. All these are the normal finding. Then we'll go to the abnormal. So again, normal, no resting activity, and be aware of end plate potential, and be aware that your setting is adjusted to 50 or 100 microvolt per division, and the patient is totally relaxed and resting. Be aware of the setting and the condition of the patient. And during contraction, the motor unit potential with bi or triphasic, certain amplitude, certain duration, and certain criteria. If I go for the abnormal EMG, I start with the spontaneous activity. I ask a patient to totally relax. There is what's called positive sharp waves. And positive sharp waves, its explanation, by the way, is variable. Most of the books describe it as due to hypersensitivity, due to upregulation with the denervation process. It's a sign of the denervation process. Another explanation, when the nerve is giving supply to the muscle, it gives acetylcholine, and it also gives anticholinesterase, helping distracting them. And they tell you with the pathology, if this is not anticholinesterase, there is also hyper-excitability of the muscle. So the explanation of positive sharp wave, mostly it's due to hyper-excitability with up-regulation of the receptors. It occurs spontaneously. But as you find here, what is the amplitude of the positive sharp waves? It's very small, 50 microvolt. So remember to adjust your machine to be able to detect this small recording. Then I will come to another form of spontaneous activity, which is the fibrillation. And fibrillation, it's firing from single motor fibers. As I told you, what is the motor unit potential? It's one nerve and a lot of muscle fibers. It's a firing of single muscle fibers, and it's mostly showing a sign of denervation also in acute neuropathic lesion. It's characterized by having a regular firing pattern. It's repeated regularly, and then it may disappear for a while, then it can appear again. And it's characteristic by a very characteristic sound, which is called as raindrops. And there is a lot of videos on YouTube where you can hear this characteristic sound of the raindrops. Its amplitude is mostly in the range of 200 or 100 microvolts. And its morphology, sometimes it's triphasic or biphasic, but mostly it starts with positive wave, downward wave, in contrast to other waves. Another spontaneous activity I can find is the fasciculation potential. By the way, fasciculation potential, it could be a normal finding in some, but in our recording in pathological states, always it's associated with long standing and denervation pattern. It's very famous for example, for the ALS or chronic radiculopathic changes. And its amplitude is much higher. By the way, we have told that fasciculation is due to activation of motor unit fiber. Motor unit potential. It's the nerve and the muscle fiber supplied by it. But the fibrillation is related to single muscle fibers abnormal firing activity. And it's always described as large raindrops, and sometimes they describe it as popcorn. When you prepare popcorn in your home, you can hear interrupted and irregular, but large sound, large amplitude sound. So it's very characteristic of fasciculation potential, and it's characteristic for pathological long-standing condition like ALS. This example to compare between the fibrillation and fasciculation. And here you can find the fasciculation is characterized by higher amplitude compared to the fibrillation, because it's a single motor fiber or muscle fibers, but this is related to a lot of muscle fibers supplied by single motor neuron. Again, this is a comparison between them, and you can find here the difference in amplitude. This amplitude is something like 100, and this can reach 500 or half millivolt. Complex repetitive discharge is another form of spontaneous activity, but it's not specific for neurogenic or myogenic pathology. It can be found in both of them, and they characterized by being polyphasic or serrated. It's an interrupted one, a run of polyphasic or serrated contraction followed by resting state, and it can be repetitive. And mostly, if it occurs repeatedly, it will occur in regular pattern. It will be repeated at regular pattern. The collective slide for some patterns of the spontaneous activity I can find. This is the end plate potential or end plate spikes, and we have agreed it's a normal finding. And this is the example for positive sharp waves, and you can find the small one, and this is fibrillation, and the larger one is fasciculation. This is the neuromyotonic discharge characterized by what's the famous pumper sound. If you hear it, you will never forget it. And also there is a lot of video records for this sound on YouTube. You can watch it and listen to it. It's very characteristic. And if you listen to it in your clinic, it will be a very nice experience. You will never forget in patient with myotonia. This is myocomic discharge and can occur in neuropathy or upper motor neuron lesion, something like MS or other cases. And it's not common to find the myocomic discharge. This is again collective example. So what is this? Positive sharp wave. and this fibrillation, and this the larger one fasciculation. So this the pattern I can find commonly in neuropathic lesion. But by the way, in some muscle disorders, especially inflammatory, I can find the positive sharp wave and the fibrillation. This is the complex repetitive discharge. Polyphasic, serrated, repeated, and then it will occur at regular pattern. This comparison between the resting state finding, but it's nearly the same that we have discussed in the previous slides. Then I will ask the patient for doing a manual contraction. So I expect that his pathology, it could be with the motor nerve supplying a group of muscle fibers. It could be the problem with the muscle fibers. When it's related to the motor nerve, during active contraction, I find a large motor unit potential. And this we need to understand because it's very strange. How come the patient is with lower nerve supply while the response will be higher during motor unit potential? Because if we look at this motor unit A supplying a group of muscle fibers, and this motor unit B supplying a group of muscle fibers. When the nerve B dies or some pathology with it, the supply from A is trying to doing a sprouting to supply more fibers, muscle fibers. So the muscle fibers of the diseased nerve are supplied by the other nerve. So when I do contraction, the motor unit that is still alive, the nerve that's alive, is supplying more muscle fibers. So response will be higher. So this is clear. This point clear. How come I am with nerve pathology and the motor unit potential is going larger? Sorry? It occurs with, it's a chronic reinnervation process. It will take weeks to months to occur. And the duration also is higher because it's recording from multiple muscle fibers. Yes. How about the myopathic EMG? If the pathology with the muscle, I have the same motor nerve supplying certain group of muscle fibers. These muscle fibers has become smaller and less in count. So when I ask for doing a motor unit potential, the patient is stimulating by the motor nerve less number of muscle fibers. So it's supposed to be smaller in its size and shorter in its duration. So in motor unit potential, I'm finding it smaller and shorter duration. This is a collective diagram comparing between this healthy one that we have started with, and we agreed to the protocol of resting and the minimal volation and the maximum volation. This is the example of neuropathic pattern. You find the spontaneous activity. You find that the wave is higher. And on doing the interference pattern, I have told you what is the definition of recruitment. I'm inviting much more motor fibers to contract, starting from maybe the anterior horn cells, the roots, the plexus, the nerve. Okay? I don't have much. The problem is with nerves. So I will not invite the expected number. So there will be recruitment, but there is not enough motor nerve to supply. So the recruitment will be interrupted. I can see the baseline in between. So despite the waves here are high, but they are not condensed together, and the baseline is still there, and there is no complete interference pattern, or what we call full recruitment. In the myopathic, there is the same number of nerves, so I'll invite a lot of nerves. I'll reach the full interference pattern, but the response for this interference pattern from a smaller number and size of muscle fibers, so the amplitude still will be smaller. So there will be full interference pattern with a smaller amplitude. A rapid comparison for the finding in myopathic and neuropathic. This in myopathy it's shorter, smaller, and could be polyphasic, and interference pattern is full. In neurogenic, it's longer duration, larger amplitude. It could be polyphasic, but interference pattern is partial. And this is a summary for the finding in some neurological. So this is a famous diagram or table that we sometimes use in our clinical practice. But again, be clinically oriented with the summation of the clinical history, examination, and your nerve conduction and EMG finding. To sum up, EMG is a reliable way, but first you have to be prepared with your equipment and prepared with your knowledge and prepared with your setting for your machine. You have to agree with the patient that we'll do resting state, so be totally relaxed. Then we'll do minimal contraction, then full contraction. Don't be mistaken with some normal phenomena that will explain it as abnormal, like interplate potential. And finally, it will be so much helpful in reaching your final diagnosis. Thank you.
So we come to the afternoon session about needle EMG. Thank you so much for that nice talk. Um, I think that'll be better. So we have a patient here today. She has kindly agreed to be our subject. So for needle EMG, I want to show you the demonstrated, and if time allows, what has been covered, I'll try to show you some examples as well, okay? EMG, needle EMG is, all the numbers are good, the duration and amplitude and whatever,